I guess you are having a nice time. I will be standing on the existing protocol to present the practical approach to management of acute pulmonary edema. My name is Dr. Adedeji Adebayo. I work with Cardiocare Specialist Hospital, a center you can always rely on in your cardiovascular care. Okay, why are we looking at acute pulmonary edema? Pulmonary embolism, rather. Embolism, rather, sorry. Okay, why are we looking at pulmonary embolism? It remains the third leading cause of cardiovascular deaths, as Dr. Miller has said, after stroke and myocardial infarctions. And it remains silent killers of human race just because of the way it presents. It makes so many diseases. What it means is it's mostly made in the clinical practice. And you should bear in mind that it has a very strong correlations with deep vein thrombosis. In those people that have PE, usually when you check and do their Doppler ultrasounds, they will always have a coexisting deep venous thrombosis. Usually the incidences are higher in people that are holders and people that are medically his, people who are admitted in the ward. You only needed the high incidence of suspicion to know that, okay, this particular patient actually has a coexisting pulmonary embolism. Now, it usually results from a triad of endothelial damage, the hypercoagulable states, and sepsis. And usually we call this the Vicos triad. Now, when this happens, it usually forms a venous thrombosis. It forms usually in the deep veins of the legs. Now, when this embolize, it finds their ways to the inferior vena cava. From there, it goes to the right atrium. From there, it escapes to the right ventricles, from where it goes into the pulmonary arteries. Now, the size and the location where the emboli occluded will determine the clinical presentations of such a patient. Now, when it happens, it will have an effect both on the pulmonary system and the cardiovascular system. But usually on the pulmonary system, it results from the increase in the alveolar dead space. Because of this, there will be a mismatch between the ventilation perfusion. There will be a ventilation perfusion mismatch. And because of this, patient will develop hypoxia. And usually, how do you detect it at the bedside? It's through our common pulse oximeter. When you check, you see the oxygen level coming down. We won't just explain why the oxygen level is just going down. The only thing patient comes with is just probably difficulty in breathing. He's now having low level of oxygen. Now, you have to have an index of suspicion that this is probably a pulmonary embolism. Now, when it happens and it blocks the pulmonary arteries, now there's a build-up pressure there in the pulmonary circulations. That build-up pressure put a stretch on the right side of the heart. Because of that, it will be distended. Naturally, the left side of the heart is bigger. It picks about 2/3 of the heart size, and the right side is usually 1/3. But when it has pulmonary embolism, the reverse is the case. Because of that build-up pressure on the pulmonary system, now the right side is dilated. Because of that, there will be a stretch. When that happens, the supply to the left side of the heart is impaired, cardiac output is reduced, and when you check your BP, the blood pressure will be low. That's the way the patient will present. Because of that, the supplies to the coronary circulation become reduced. Patient can have some microischemia on the right ventricle. And that's the reason why when you do your troponin, in some patient that has pulmonary embolism, they can have an elevated troponin. Now, usually if a patient is presenting and you are suspecting that this patient has a pulmonary embolism, usually these are the 6 steps that you can actually follow in evaluating such a patient. Usually the first thing is the clinical presentations. You come with difficulty in breathing. You examine the chest. You didn't find anything remarkable. But the only thing you realize is that this patient's oxygen level is just going down. Those are the patients you want to suspect pulmonary embolism. Now, usually it's a 6-step thing. Now, when such a patient comes in and you check your BP, the BP is normal, 120/80. He has these symptoms you are suspecting. These are the patients. You follow this step ladder approach in the evaluation of such a patient. When you have that, the other step I will explain further. But one thing I want to mention is that if a patient is coming and he has these symptoms, you check your BP is low. You will skip this 1, 2, 3, 4. You just go to your 5. Because at that time you need the bedside echo to actually ascertain why is the BP low. Because once you pick that, the dynamics of management change immediately. Now for the step 1, usually as I said, is a masquerade of so many diseases. You needed a high index of suspicion to be sure that this patient has a pulmonary embolism. What this means is that it's not all patients that come with difficulty in breathing that is heart failure. It's not all difficulty in breathing that is asthma. It could be a pulmonary embolism. Especially when you examine, you look at the chest, it's nothing remarkable, but the saturation is going down. You have to think about it. You admitted a patient in the ward, initially okay, but now realize it's desaturating. Patient that has spent 48 hours in the ward, 72 hours in the ward, you need to start thinking about pulmonary embolism. Now, the classical presentation, as I said, is unexplained difficulty in breathing. About 50% of them can come with chest pain. Now, the locations of the embolus will determine the type of chest pain. If it's very, those are the ones you see a pruritic chest pain. In that instance, you have the task of differentiating from a pneumonia. If it's central, it could be angina-like, meaning that it's more of a exertional chest pain. Now, if it is massive, you can come with this syncope, pre-syncope, and all those ones. And some of them can come with hemoptysis, meaning that not all hemoptysis are TB. Now, when you now have a patient that you are suspecting a pulmonary embolism, BP is okay, more than 120/80, 110/70. Now, but you want to ascertain that is it really a pulmonary embolism? Now, you follow this particular score. Patient with clinical signs of DVT, usually they come with unilateral leg swelling. There could be pain on the calf. If you have such a patient, it's going to have a score of 3. Now, if we are sure that the diagnosis cannot be explained by any other thing other than pulmonary embolism, the score will also be 3. Patient at the bedside, pulse rate is more than 100. The score is 1.5. You admitted a patient, now up to 3 days in the ward, is developing difficulty in breathing. That patient has a score of 1.5. Or somebody that had a surgery in the last 4 weeks, even discharged, now coming to see in the clinic with difficulty in breathing, he has a score of 1.5. Previous DVT, 1.5. Hemoptysis, 1. Malignancy, whether on treatment currently or it has previously been treated, it's also a score of 1. Now, when you do this summation of this, a score that is less than 4, P is unlikely in that instance. It's a low risk of pulmonary embolism. But if his score is up to 4, those are the ones that the likelihood is very high, and those are the ones you go ahead to do your CTPA. Hello? I said what? CTPA. If it's less than 4, it's low probability. Those are the ones that you want to go ahead and check their D-dimer. If you do your D-dimer, if it's lower at that instance or normal, that means PE has been ruled out. Because D-dimer is a product of the breakdown of the clot that is formed, usually from fibrinogen. That's what the D-dimer is actually assessing. Now, meaning that if you do your D-dimer and it's normal, meaning that there's no clot anywhere. And that's why the D-dimer is not elevated. In that instance, pulmonary embolism excluded. But if you now do your West score is more than 4, you don't need to do D-dimer again because these are more of high risk. You just go ahead to do your CTPA. Now let's assess. Let's see who is following me. Now this is a patient, 41-year-old woman that presented with sudden onset of difficulty in breathing and chest discomfort for about 12 hours. He has associated sweating and cough, no hemoptysis, no fever. The chest discomfort does not radiate to the left or the neck. He's not a non-hypertensive or diabetic, and there was no previous history of pulmonary embolism. Neither smoke or take alcohol. He however had myomectomy about 4 days ago for symptomatic fibroids. She was not on oral contraceptive pills. Now, on examination, she was tachycardic, BP was still normal, GBP was not raised, heart sound was 1 and 2, other than the loud P2. He has a tachypneic and is desaturating. Now, if you look at this, what's the likely Wells score of this patient?
All right, what's the Wells score? Can we calculate?
What's the likely Wells score?
Just go back to the previous slide. Let them see the Wells score again. What's the Wells score? Somebody say 3. Everybody can calculate the Wells score. It's not for specialists. All right, what's the likely Wells score? Go back to the case. All right, so now let's calculate together now. What do we think? Somebody say 3. Somebody say more than 3. Yes. Yes, what do you think, ma? Yes, what's the Wells score? Those of you not paying attention, I'm coming there.
6.
6, how did you reach 6?
Respiratory rate was 102. It's more than 100.
That's how many scores?
1.5.
1.5.
She had a previous surgery less than 4 weeks.
Okay.
That's 1.
That's another 1.5.
5. Yes. She has symptoms that are consistent with PE. She had cough, she had chest pain, and she was breathless.
Okay, excellent. Sudden onset difficulty in breathing in a woman that had surgery in about 4 days ago.
Okay, do we understand that? So we can see how we can calculate. Anybody can calculate it. Now, very important about it is that there is no other diagnosis that is more likely to explain it. So let's say she had fever, she had other things that can say, okay, maybe, but the fact that it is sudden is very important. The SpO2 is low, it's very important. She has myomectomy, risk factor, very important. So it's very likely. So based on this now, we now calculated the Wells score. Now the Wells score of 6, is that positive or negative? Positive. So what do you do for a positive Wells score? CTPA straight.
Yes, if you can look at this, the answer here is 6, and you go straight to your CTPA. You can see this is 6, as he said. You follow the last, you just go straight to CTPA.
Now, if you don't have CTPA, you can still do D-dimer on your way so that you can extra increase your confidence. Okay.
Now, we are now going to step 3 and 4 of that, the step bladder assessment of patients with pulmonary embolism. As I said, the D-dimer is basically to assess the risk of a thrombus that is formed, especially in people that has a low to intermediate risk of pulmonary embolisms. Now, once your D-dimer is normal, you know that P is excluded. Now, but if it's positive, it increases your suspicions in those ones that has low intermediate risk. In that instance, that means you will go ahead to do your CTPA to confirm your diagnosis. Don't forget that D-dimer is not a diagnostic test. Now, the next one is the troponin and the brain nitrate peptide. Basically, it's not for diagnosis. It's just to further stratify your patient. Because if you have a patient that has a pulmonary embolism, don't forget I mentioned stretch on the right side. There's a stretch on the right side. Because of that stretch, there's production of brain nitrate peptide. Because of the micro-infarctions on the right ventricular wall, there's elevated troponin. Now, if you see those tools, it increases the risk of your patient in somebody that has pulmonary embolism. These are the patients you look at. Because if at all is coming in with a normal BP, those are the class of patients that, while they are in the ward, they can actually deteriorate. They can deteriorate, they become an high-risk patient, and you have to start considering thrombolysis in such a patient. Also, if at all you miss this patient, these are the patients that long time, they are at risk of complications. They have chronic pulmonary embolism, pulmonary hypertension. If you see the patient that have the chronic pulmonary hypertension in the past, you will know that detecting this and treat when you pick them is very important. It's only very burdensome. Come with this refractory bilateral leg swelling. Everywhere is swelling. Those are the complications. Now, for the ECG, when you do usually the most commonest thing you see is sinus tachycardia. Other thing may be normal. In fact, in some instances, it could be a normal ECG. But in some of them, the only thing you see is sinus tachycardia. Others, you could see features of right ventricular strains, T-wave inversions in V1 to fever, and they could have right axis deviations, either complete or incomplete right ventricular bundle branch block. That's our step 4. Now, as I talked earlier, Acute pulmonary embolism with hemodynamic instability. What defines an hemodynamically stable patient that is coming with pulmonary embolisms? Now, one, they can have a cardiac arrest, meaning that you needed, as Oga said yesterday, the pulse will be absent, cardiac activities will be absent, they can have an agonal breathing. Those are the class of patient. Patient that has obstructive shock, meaning that the systolic blood pressure is persistently less than 90, and they have features of end organs hyperperfusions. Third, they can have either a transient or a persistent hypertension. Those are what defines somebody that has hemodynamically unstable pulmonary embolisms. As I said earlier, once that step ladder approach to evaluation that I mentioned earlier, you skip from that step 1 to step 5, and this is it. You need a bedside echo to look at the right side. Usually what you see is a dilated right ventricle. The ratio will be reversed. The right will now be more than the left. The right ventricular wall will be hypokinetic, and you could see 60 signs basically the pulmonary acceleration time is less than 60. The peak pressure for tracheotomy regurgitation is also less than 60. Now, when you do your CT pulmonary angio, what you see basically is a what? Is a central filling defect in the pulmonary artery. However, there are contraindications to it. Patients that have renal failure, but don't forget the contrast for CTPA is going to be excreted by the kidney. You don't want to worsen the baseline clinical characteristics. Allergy or somebody that is pregnant. Now, these are the findings that you can see on echo. This is a patient that I presented earlier. This is the CT of that woman. Now, this is just a summary. But while you are doing that, you always have to have at the back of your mind the likely differential diagnosis of a patient that is called pulmonary embolism. It could be MI, it could be pneumonia, it could be acute heart failure. Now, this is just an algorithm that summarizes what I've been saying since morning. Patient is coming with what looks like pulmonary embolism. The question you are going to ask next, is he hemodynamically stable or not, based on those earlier defined criteria. If it's unstable, I said, what you needed next is your echo to confirm that the right side is okay. Because once the right side is dilated, in the settings of a suspicion of PE, the dynamic for treatment will change immediately. Now, once it's there, if we are applicable, you can actually go ahead to do your CTPA. Now, if it's not, that means the BP is okay, your suspicion is still this, you assess your well score, as I said earlier. If it's positive, or if it's negative, that rules out your pulmonary embolism. But if it's positive, you go ahead to do your CTPA. And if it is positive, those are the ones you anticoagulate in that order. But if it's hemodynamically unstable, as I said, the treatment is for you. We want to dissolve the clot that is formed there. And that means, in this instance, it's more of a thrombolysis that you're going to do. Okay, this is just a scheme explaining what I've been saying since morning. Acute pulmonary embolism, low risk if the BP is okay. You did your echo, right side is fine. Your biomarkers are normal. These are just anticoagulate them for 3 to 6 months at least. Now, this one, suspected PE, BP is low. These are high risk. These are the ones you thrombolize. Now, there is this intermediate class. When they are coming, PE, you did your initial BP was normal. But when you did your echo was dilated. If it's dilated without elevated biomarkers, these are low intermediate risk. Those ones you just continue anticoagulation. But RV is dilated, biomarkers are elevated. Those are the ones you have to be on the look. They can go down, and once they go down, you want to thrombolize. Systemic thrombolysis. Now, the goal of treatment, how do we treat? Goal 1, reperfusion therapy is high risk. In those ones that are low risk, you just treat and prevent recurrence, and you address the complication where it is present. Now, in those ones that are coming, as I said, hemodynamics, oxygen usually low. You want to give oxygen. Low BP, you want to give a cautious normal saline, nothing more than 500. Because if it's more, you are going to worsen the right problem. Now, as per perfusion, and some of them can benefit from ionotropes. to support the BP. Now, the treatment, if the perfusion therapy could be systemic or catheter-directed. Systemic, we follow normal standard protocol through our normal IV line. Why catheter-directed means you are introducing a catheter either through the femoral or you are using radial and take it directly to the pulmonary artery and allow the drugs to be dissolving the clot that is formed already. Now, and surgery, depending where it's available, if you are contraindication to systemic thrombolysis. Anticoagulation, that I said, first lines, there are these newer drugs, the NOACs. Exceptions are those ones that are pregnant and other contraindications to this. IVC filters in those ones that have contraindications to systemic thrombolysis, or somebody that have a recurring thrombolysis. Now, for thrombophilias, treatment is usually lifelong. Thrombophilias are those ones that they have this genetic derangement in those natural anticoagulant, protein C, protein S deficiency, people with antiphospholipid syndrome. Those are the ones that are on lifelong treatment. Now, complications, chronic thrombopulmonary embolisms. These are one of the complications that patients that are missed, pulmonary pressure with more than 20, and usually local to where the clot is and dissolve it continuously. And in this one, it was more of a catheter directed that we did, not the systemic thrombolysis. Okay, this is a summary. Patient was discharged after 6 days. We discharge on rivaroxaban, usually 15 milligram BD. You start for the first 21 days. Later, it was 20 milligram daily for 3 to 6 months, and we have been seeing this woman in the clinic. Now, if you look at this is the repeat. 72 hours after thrombolysis. This is the initial one. If you compare it, though it's not less than this, but it's closer compared to what it was initially. Okay, this is the second one.
We need to end now.
Okay, something similar to what I discussed.
Any questions?
Something similar.
Any questions? So, PE, we have said, number one, sudden dyspnea, sudden breathlessness, often, worsening. We'll now classify whether it is very high risk or not by what? Blood pressure, not so?
Yes, sir.
Low blood pressure, cardiac arrest, even if it is transient low blood pressure, that is a very high risk and you need to treat immediately. Typically, you would need specialist input at that point. Now, if it is blood pressure is fine, we will now look at other things. For those with abnormal echo or those with abnormal biomarkers, we can now put them towards intermediate risk and we watch them very closely, typically in ICU. At some point in time, we may have to progress to treat them like high risk because if they are getting worse. But in some other cases, people don't have many symptoms, they do well on oxygen, we just continue anticoagulation. Anticoagulation is typically for a minimum of 3 to 6 months afterwards. And most times, patients will do very well when they are treated on time. Okay? Now, very important, one of the presentations we talked about is that they can come with a cardiac arrest. They were on the ward, they were fine, they were about to be discharged tomorrow from stroke or from any other thing, from pneumonia. And suddenly, they say somebody came to see them. Everybody said that person brought jazz. They did not bring jazz. They developed P and got a cardiac arrest. In the process of doing our resuscitation, we made the diagnosis. And then we can thrombolize during that code. While you are doing your CPR, sometimes you can thrombolize. Okay? And then you continue up thereafter. So patients typically can do very well if you're able to get the clots out. All right. Can we give a round of applause for Dr.
Thank you, sir.
Dr. Fortune? Any burning question? Burning.
Okay. There's somebody at the back.
We have about, I don't know how we'll do this time. Let's do ECG before we do this one.
Thank you very much, sir.
Yes.
I'm Chijoki, I'm a physiotherapist. Okay. And my question is, knowing everything here, I think it's both a question and more like a suggestion, and that is about bringing us in as the physio team, because sometimes we can see patients and then we're seeing certain red flags, and then you're trying to communicate that to the appropriate professional who is meant to see, maybe refer to cardiology or refer back to the referring doctor and all of that. So I think it would be nice to look at both the tertiary prevention and then the primary care, how to integrate physiotherapists. I'll be very, very glad to know and also communicate with my team. And again, I would also like to, if there's any way that we can make this kind of training, I know this is not for you, the team generally, to make this kind of training compulsory for physiotherapists. Thank you very much.
Thank you, sir.
I didn't get the question very well.
The training of
more of a recommendation.
Integrate. That's why you are here. You are integrating.
Now, but you mentioned something about the primary, secondary, or something. Now, I didn't mention this, but if you are admitting a patient and you are anticipating that this patient is likely to be more than 48 hours on your bed, there is no harm. You need to start a prophylactic anticoagulation. Because don't forget, I said it is more in those that are medically healed. They have other comorbid things that they are managing. Endothelial injuries are ongoing. Probably he has a sepsis. And you're anticipating that this particular patient is going to be on my bed for 48 hours. You need to start anticoagulations prophylactically so that it won't be as if you are managing something, the patient is developing another thing.
All right, so very important. Prevention is better than treating PE. A lot of times, you see all these things we talked about, sometimes you never get an opportunity. The patient just dies suddenly. Now, very important about physiotherapy. So our standard, and for all of you that are in ACS 2025, our standard is generally any patient above 40, especially those that have an underlying illness, that you think will be on admission for more than 48 hours, please give prophylactic anticoagulation. Either clexane and enoxaparin or heparin. Almost all of them must be, except there's a contraindication, which you must document. And if there's a contraindication, make sure that you have them move around a little bit or wear some stockings that can prevent it. So if a patient is in the ICU, and it's not that they are bleeding or had an issue, they almost always must be on anticoagulation to prevent PE. A lot of people that die in ICU die from PE, not from what brought them in. People that die from stroke, a lot of them die from PE. And that brings me to the physiotherapy guy. A lot of times people come and say they have leg pain, one leg pain or the other. I have seen it time without number, and the physiotherapist starts massaging the leg, and 30 minutes later the patient is dead. Okay, so in terms of physiotherapy, very, very important. And nursing, unilateral leg swelling, especially with pain, must be assessed before anything is done. So I saw one patient, I was so impressed with the physiotherapist that she went there, she was having leg pain and this, and the man said, what? One-sided, touch it pain, and he said he's not doing anything. Go to the doctor. I have never been so impressed with anybody like that. Okay, some other people will just collect and start doing, before you know it, boom. There are so many cases. So leg swelling, leg pain, no. There must be somebody that certifies. 2, if you are going to do physiotherapy for people that have been on admission or have been immobile for a long time, you should make sure they have been on some form of anticoagulation. And if they have not, you need to take special precautions from the managing physician. Why is the person not on anticoagulation? And are you sure you want to go ahead with physiotherapy? Because if not, you are the one that will do. Why? They could have small clots in their legs, and once you just massage the leg, you will help to push the clot straight in. Some people will get to the hospital, some will never get. Okay, so very, very important. Thank you for that question. We need to go into 14 around now. It's not around.
Hello, sir.
It's around. Okay, come now, quickly.
Okay,
you have
sir,
3 minutes.
My own question is as regarding most of my patients, I think I'm a dialysis nurse, so they're having dialysis and through their central line, and then air goes in through the central line. I think just a few days ago, I had a patient that was in the ICU, was on clexane, and then had a femoral artery repair, and we're battling it, and then blood went through, and we had a very similar case of PE. So through the weekend before this symposium, I kept wondering, what did we do wrong? The patient was...
So say again, you were doing dialysis and what happened?
No, this patient was a renal patient. Post-dialysis, I think in fact he weren't able to complete the session 2 hours into the session. The patient was already becoming breathless.
Yeah.
But the patient had a background history of... there was an aneurysm, so they were correcting it. And this patient was on 15 liters of oxygen. In fact, the moment I stopped the session, we put the patient on high. And then this patient already was on Clexane. And in fact, I think he was having, because before the Clexane, he was on heparin IV infusion, just so that because of the suspected clot. So I kept on trying to think, where did we get it wrong, or what did we miss? Because eventually we lost that patient. You will lose that patient, unfortunately. No, I'm not saying you did anything wrong. I'm saying that unfortunately you will lose that patient. I'm not castigating you. Just so PE is deadly. It's deadly. Unfortunately, giving prophylactic anticoagulation does not 100% exclude deformation. So in those kind of very high risk patients, you may have to add pneumatic compression stockings. So you have this big thing, we connect it to light, and it's giving air and pressing the leg, pressing. So as soon as they come in, especially when you cannot give good dose of prophylactic anticoagulation, you need to wear the big stocking. It has airbags like that, so it will be pressing the leg continuously while you are giving maybe a lower dose of your Clexane or whatsoever. Now, in some people, despite that, they may still have it. They are extremely high risk. If you notice that they are such high oxygen requiring, and you've done all of this and it's very likely PE, you may have to treat the PE before the dialysis. And in this case, you might have to do the systemic thrombolysis or take a catheter straight in there and try and break it up. Or better still, take a catheter there and extract the clots. So we have a catheter called an inari thrombectomy catheter, which we take from the groin. It's a very big catheter, pass it through the right heart, go into the pulmonary artery, and suck out the clot and bring it out all at once. So that will have been perhaps the rule, especially when the patient started going down. Immediately you had to stop the dialysis, and thus was that your first thought should go towards PE. And immediately you should be thinking of thrombectomy or what they call it, thrombolysis, either catheter directed or systemic. In this kind of case, I will choose catheter directed because there's likely of bleeding everywhere. So you take the catheter to there, and you will give in a small dose, unlike the one you give systemic, because you are now over the clot. The person will now typically. So in those kind of patients, what we have seen, I presented a case series of about 17 cases in Senegal last week, and then in NCS during the year. They normally go off oxygen within 24 hours. It is that dramatic because you would have taken out the clots, the thing will break it up. It's really dramatic. It's expensive, but it's dramatic. It really, really works. So in those cases, that's the way you could have handled that case. But I cannot tell you that you did anything wrong or right. It's a very difficult case. There's no easy way out. But like we have said, P is a masquerader. We should be extremely ready, extremely prepared. It could happen at any time and it could happen to anybody. Okay? But it should typically not happen for a patient on your ward. And one of the key things is to prevent and be on prophylactic anticoagulation, and also to recognize it quick. Immediately it's happening. Those well score, the nurse should calculate it and say, doctor, this is what the well score is. The nurse may even request the D-dimer if it's allowed in your facility. Request it so that you can have that evidence. Everybody's mind will go there. Then we can now start thinking of thrombolysis, either systemic or peripheral. Thrombolysis works. It's expensive, but it works. Sometimes it's more expensive to do burial. So don't forget about cost. Money is not as important as life. Think about what is best for your patients. Think about what is best for your patient and offer it to them. Don't think about, it's costly, let me not offer it. That is bad practice. Okay, we will get there. We will get there. Before ECHO was not everywhere, CT was not everywhere. Now we are doing CT every day. Okay, very importantly. Thank you very much.